Okay. So this is a case-based presentation we see here. So my topic here is advanced management of this patient based on final diagnosis. So here we can see that we are dealing with an RV failure patients. Maybe that's a TR patients or maybe cor pulmonary or constrictive pericarditis or restrictive cardiomyopathy. It's an RV or right heart disease we are dealing with. There may be so many differential diagnoses, but final diagnosis, if we say or if you think that rapid white descent, first thing comes to our mind is constrictive pericarditis, as long as the history takes us to. So, what are the etiologies of this constrictive pericarditis? We know that, as the international literatures are saying, that idiopathic or viral pericarditis that leads to constrictive pericarditis amounts to around 50%. Post cardiac surgery is around 10 to 15%. Post radiation is around 5 to 10%. Autoimmune or pericardial injury, that is around 5 to 10%. Tuberculous pericarditis, there is no data available in international books. But in API in 2017, they are quoting around 30 to 35% of constrictive pericarditis in India and Indian subcontinent are from past history of tuberculosis, maybe active or passive, active or inactive. Other purulent non-tubercular bacterial pericarditis are there, and miscellaneous like malignancy elsewhere or malignancy in the pleura or pericardium, reaching pleura and pericardium, trauma, drug-induced, and sarcoids. So these are the usual etiologies of constrictive pericarditis. If we place that this case is due to constrictive pericarditis, this is our final diagnosis. So we have to be very cautious. So these are the etiologies we are dealing with. So we have to calculate these things. So after we reach our diagnosis, we should review that thing by usual tests. What are those things? ECG is not that much confirmatory. Chest X-ray, there may be some pericardial calcifications. These are a repetition thing, as Ovik has already mentioned. Inflammatory markers, these are coming up in a big way for the last 5 years, ESR and CRP and HSCRP. For the inflammatory markers, it is an active or not. Echo, definitely TTE and TEE are very much important for diagnosing and finalizing our diagnosis as constrictive pericarditis, or having any clue that what are the etiologies of this constrictive pericarditis: pericardial thickening, abrupt posterior motion of the ventricular septum in early diastole, abrupt anterior motion following atrial contraction, inspiratory septal shift, dilated inferior vena cava, plethora. These are the usual signs we see here, and some strain managements, the atrial strains and ventricular strains, leaflet strains. These we can see here. Lots of features are there in echocardiography from where we can have an idea of the etiologies of constrictive pericarditis. Next, cardiac cath. We should revisit after we make the differential diagnosis and toward inching towards final diagnosis. We know the cardiac cath features. Mostly, LA is dilated, but not more than 50. All the diastolic pressures are same, almost same, not more than 3 to 5 in any chamber, and RVSP is more, but not more than 50. These are the usual crux we get in this cardiac cath. This is cardiac CT. Here we know that pericardium is thickened more than 3 millimeter, more than 4 millimeter pericardium is thickened here. Next is pericardium calcification is a diagnostic of constrictive pericarditis, most likely tubercular or origin. This is a cardiac MR. Usual CMR and gadolinium enhancement, these are gaining popularity day by day for the last 5 years. The CMR, mainly LGE, that is late gadolinium enhancement, has been incorporated in every books and every guidelines that this should be done before embarking on pericardiectomy. That is a uh, your treatment modality in constrictive pericarditis. Here we can see that pericardium thickening of pericardium in these two arrow portion, and that is the LGE, late gadolinium enhancement in the pericardium, suggestive of constrictive pericarditis. So here we can see that if we see the algorithm behind this finalizing our diagnosis: mitral E by A more than 0.8, E prime more than 9, ventricular septal shift with respiration, hepatic vein expiratory diastolic reversal ratio is more than 0.8. So these are the usual crux. If all the three parameters are positive, then constriction is likely. If one or more is positive, it is possible. So that's why we are finalizing this thing. Constrictive pericarditis is usually categorized as acute, subacute, chronic, effusive constrictive, transient. So these are the usual, nomenclature we can find in textbooks of Grunwald and Hurst, and they divide it in maybe post-tubercular pericarditis, constrictive pericarditis, non-tubercular other bacterial pericarditis, indolent or recurrent pericarditis leading to this constrictive pericarditis, and radiations and other things, post-cardiac surgery and these are things. Because before embarking on specific treatment, we should know what is the exact mechanism. Because if this is a radiation-induced constrictive pericarditis diagnosis, we made this diagnosis, then it is difficult because that doesn't yield well. So here we can see the initial treatment is NSAIDs plus colchicine. If we get a good response, continue treatment for 3 to 5 months, then slowly taper off NSAIDs. One, we can take off NSAIDs, then we discontinue colchicine. This is the usual dictum. If there is an inadequate response to this NSAIDs and colchicine, you can switch to glucocorticoid plus colchicine. That is steroid plus colchicine. You have to continue it for 6 months at least. If the patient tolerates this thing, then we can taper off glucocorticoid and monitor the symptoms. What are the symptoms we should look for? Number one is symptomatic improvement of these patients. If we see, again, repeat LG, that is CMR, gadolinium enhancement decreases, pericardium thickening decreases. And if we do a cath, all the parameters decreases. Diastolic pressure and TR, usually it's not that much yielding, but other parameters decreases. And nowadays we are talking about this interleukin-1 inhibitor. Is 2016 and 2021 there is a large 500 studies papers published that interleukin-1 inhibitors are gaining momentum in the treatment of constrictive pericarditis. In every patient, before we embark on pericardiectomy, we should give a trial of this interleukin-1 inhibitor that can have a potential to improve your symptoms. So here, these are the drugs we know: aspirin, ibuprofen, indomethacin, colchicine. These are the dosing schedule, and this is the tapering schedule, how you can taper off these molecules. Prednisolone, steroid dose, usual colchicine dose is different. That is 0.6 milligram orally 2 times a day. Usual duration is around 3 to 6 months. These are the ritonavir and anakinra. We know that interleukin-1 inhibitors. Now these are gaining momentum. How to use it and what is the dose? It is written here: 1 to 2 milligram per kg ST daily administration anakinra. Azathioprine, these are the steroid sparing agent. IVIG has also a role in constrictive pericarditis. So here we can see that constrictive pericarditis is different from other RV failure or this RV right heart diseases, because it is a mechanical constriction, mechanical compression. So that's why the mainstay of therapy is pericardiectomy. What are the indications? We know that it's a horrendous surgery, as the Brunwald is quoting this, an horrendous surgery, because its mortality is around 5 to 20%. Still now in 2023, the mortality rate of pericardiectomy is high. So usually these constrictive pericarditis cases we see in medicine ward, not in cardiology ward. This cirrhosis type presentation, CLD type presentation, presents with, and JVP is a good sign. Kussmaul signs and other signs are there. Then we do an echocardiogram, then do a cut, and then finalizing our diagnosis of constrictive pericarditis. So once my guide told me no constrictive pericarditis patient should go to your pericardiectomy without getting an ATD. So in our scenario, maybe in CCP, the etiological etiology is tuberculosis in more than 35% of the cases, but that not that much literature I could fetch in internet. So indication of doing a pericardiectomy: symptoms and signs persisted despite 6 to 12 months of interleukin-1 inhibitor. This is the first line. Symptoms are moderate to severe, NYHA class 3 or 4. Not that much end stage, that is calcification is not encroached from pericardium to myocardium. No concomitant restrictive disease, LV function is preserved. If these parameters are good, then only you can embark on pericardiectomy, because it's having high mortality even today. So, I mean, patients unlikely to benefit from pericardiectomy. What are the patients subset? Are LV dysfunction. If patient is having myocardial depression, especially cardiac output is less than 1.2 liter per meter square per minute, then this perioperative mortality, morbidity is high, and chance of relapse is more. So in those cases, we should restrict ourselves to medical management. Hypoalbuminemia, especially it is due to protein losing enteropathy from CCP. It's a bad sign. Cardiac cirrhosis has already set in. This is a bad sign. Mixed constrictive restrictive cardiomyopathy. There is radiation-induced constrictive cardiomyopathy. Its prognosis is bad, and pericardiectomy is not that much efficient in this case because it is difficult. So this we should remove. Then partial pericardiectomy, this one thing we do, pericardial window, especially in recurrent pericarditis. Recurrent pericarditis is there. In this case, we usually do this partial pericardiectomy. Fluid reaccumulates. Risk of acute ventricular dilatation after surgery with subsequent RV failure. Acute RV failure is a known complication of this thing. And another thing is that radical pericardiectomy. This is I mean, the preferred one, constricting parietal and epicardial visceral layer as much as possible, scrape it out, including the layers over RA, SVC, IVC, and inferior part of the SVC adjacent to the diaphragm while preserving bilateral penictum. This is the usual dictum of this radical pericardiectomy, but its mortality is higher. Another is Weifel procedure. There is a vertical incision given along the pericardium, parietal pericardium. It's a usually this procedure is now being done. It's less. I mean, surgeons can do it without CPB and less traumatic. This is complications: excessive bleeding, atrial and ventricular arrhythmia, ventricular wall rupture, phrenic nerve injury, and this CP recurrence. These are the usual side effects and complications and risk we know after this pericardiectomy. There, another important thing that atrial fibrillation is rampantly common in this constrictive pericarditis. If we see that patient is having tachycardia, do note that thing, because if this is a sinus tachycardia, do not add beta blocker or calcium channel blockers because they depend on this rate. Otherwise, low output may again dampen the patient's clinical symptoms. So if there is a arrhythmia, lanoxin, they're still quoting that lanoxin is good because beta blockers, they're skeptical using beta blockers because RV output becomes less with beta blockers. Next, 2015 ESC guidelines, class 2B recommendation for use of interleukin 1 inhibitor in recurrent or indolent pericarditis. In last 7 years, tremendous growth in data supporting interleukin 1 inhibitors. Rilonacept is the first FDA-approved therapy in patients with recurrent pericarditis and constrictive pericarditis having inflammation ongoing. Emerging data support modifying therapies in response to CMR findings is an important one. This anakinra and rilonacept airship is a study in 2016, and Rhapsody is a study published in 2021. The term they're using that corticosteroid dependent colchicine resistant recurrent pericarditis. This is the term where you are finding that more than 3 recurrences and there is an elevated CRP, that is inflammation is going on. These are the subsets they were included in their inclusion criteria. So here we can see LGE is there, pericardial effusion is there. The second one, LGE is there. There is not much pericardial effusion. Triple therapy, that is your glucocorticoid, colchicine, or other NSAIDs you can see. Last one, there is no that much LGE. So in that case comes rilonacept or interleukin 1 inhibitors. So first recurrence, NSAIDs and colchicine. Second or multiple recurrences are there, NSAIDs, colchicine, check CMR and CRP. For inflammations, low CRP, LG negative corticosteroids. If LG positive, prefer interleukin 1 inhibitors over corticosteroids. So these are the usual dictums. Nowadays, we are getting a retrospective study of 500 recurrent pericarditis patients showed that use of such CMR guided therapeutic approach decreased recurrence and exposure to your steroids and pericardiectomy. So this is in nutshell constrictive pericarditis and advanced management. If we finalize this as constrictive pericarditis, if the other things are there, if RVCMP and a tear or pulmonary, So they are different altogether ballgame. Their advanced management, specific managements, targeted managements are different. So to conclude, earlier use of interleukin-1 inhibitors in patients with the inflammatory phenotype of pericarditis, integrating advanced imaging, especially CMR with LG, are the emerging therapies for the management of this constrictive pericarditis, especially before embarking on pericardiectomy, as this is having a high mortality and morbidity surgery. We should use a CMR and advanced imaging modalities to look these patient substrates will be benefited from anti-inflammatory therapies like interleukin-1 and other therapies. Thank you.
Great.